Hello. Our quality improvement project is enhancing glycemic control in non-critically ill patients with type 2 diabetes mellitus on medical floors. Rates of type 2 diabetes mellitus diagnosis have dramatically increased over the past decade. A significant number of diabetic patients are being admitted to hospitals with a prevalence around 11.6% in the U.S. Noncompliance or lack of standard inpatient hyperglycemia management protocol causes improper glycemic control. Consequently, a glucose of 180 while inpatient has a direct effect on patient outcome and length of stay. It has been shown in a consensus published by the ADA, American Diabetes Association, that hyperglycemia in hospitalized diabetic patients is associated with an increased risk of complications, mortality, a higher rate of ICU admissions, and a higher need to transition to rehabilitation facilities after discharge. Therefore, it is important to correctly identify diabetic patients, to document their home medication regimen, and to initiate inpatient glycemic control protocols. Our project aims to collect data on patients identified as having type 2 diabetes, calculate the percentage of these patients started on inpatient glycemic control protocol, and determine a strategy that will ensure a more significant proportion are appropriately started on this protocol. Per the 2023 ADA guidelines, it is recommended to initiate a regimen consisting of basal insulin, prandial plus correction insulin for non-critically ill hospitalized patients with adequate oral intake, or a basal plus correctional insulin for patients with poor oral intake if initial glucose is above 180. Goal is to maintain glucose between 140 to 180. This initiative will focus on enhancing diabetes care and reduce the incidence of hyperglycemic events during hospitalization. Ideally, this intervention will improve patient outcomes in the hospital and extend the benefit following discharge. For our study, we engaged a random selection of 135 patients admitted to DMC Huron Valley Sinai Hospital in the past 3 months who were diagnosed with type 2 diabetes per the ICD-10 code E11.9. These patients were admitted for a reason other than type 2 diabetes, but were ascribed the diagnosis through detailed and thorough history taking. We applied a retrospective cohort analysis to obtain our data. Our primary outcome measure was the number and percentage of this cohort who were placed on inpatient glycemic control protocol as described above. We are provided with a list of 135 randomized patients admitted between July 1st, 2024 to September 30th, 2024 with a diagnosis of type 2 diabetes as specified in our methods section. Among our cohort, 65 patients, around 48%, were placed on an inpatient glycemic protocol while receiving inpatient management. Our findings indicate that 48% of hospitalized patients diagnosed with type 2 diabetes were placed on a glycemic control protocol. This rate is suboptimal and suggests a systemic gap in inpatient diabetes management, but is still considered an improvement from our last year's results, which were around 41%. Strategies aimed at enhancing the implementation of glycemic control protocols during hospital stays could involve various approaches. One potential strategy is incorporation of electronic medical record triggers to prompt consideration for patients identified as having type 2 diabetes. This could be integrated into hospital admission orders, like protocols for VTE prophylaxis in high-risk patients or administering stool softeners when initiating narcotic medications. Additionally, establish standardized practitioner protocols to screen for type 2 diabetes and offer glycemic control protocol to identify patients may also be effective. Increasing the activation of these protocols during hospitalization could potentially reduce complications, shorten hospital stays, and facilitate proper diabetic education for patients. However, it is important to acknowledge limitations in this study. Firstly, it didn't capture data on patients who declined to participate in the glycemic control protocol. potentially creating compliance gaps. Secondly, qualitative data to assess subjective patient benefits and outcome measures like length of stay were absent. Exploring such outcomes would necessitate a control group, which was not part of our study. Nevertheless, this study sheds light on likely systemic issue with significant implications. The data suggests room for substantial improvement in the public health response to achieving tighter glycemic control. Future stages of our study should broaden the range of our outcome measures as previously outlined and incorporate methods to evaluate the effects of these interventions. Achieving success with these interventions on a smaller scale could have far-reaching implications and address a major contributor to morbidity and mortality within our healthcare system, type 2 diabetes mellitus. Thank you.